As we welcome up Dr. Julia O'Connor, I'll just, you're not allowed to talk about other people's kids, but you're allowed to talk about your own. And so I'll just say that one reason you haven't heard Juki screaming, knocking over furniture, hurling himself at people is because of the help that we've had from Dr. Tierney over the years. He's on guanfacine and Seroquel, and he sleeps through the night, and we also take him on long walks, so that's worked out really well. Just one person's support for what Dr. Tierney has been saying this afternoon. And now I'm going to introduce Dr. Julia O'Connor. She's a research scientist and psychologist at the Kennedy Krieger Institute, who is Director of Day Treatment Services for the Neurobehavioral Unit Outpatient Clinic in the Department of Behavioral Psychology. She's also an assistant professor in the Department of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine. Ladies and gentlemen, Dr. Julia O'Connor.
Good afternoon, everybody. And I know you've been sitting a while, so feel free to get up and move if you want to, that's fine. So I'm going to focus more on the behavioral approaches that we use to assess and treat problem behavior. I've been working at Kennedy, it'll be 30 years on July 1. So I've been working with kids with the most severe challenging behaviors for about that time. So these are kids that have neurodevelopmental disabilities as well as challenging behaviors. And I use kids in a very general term. I've worked with individuals as young as 10 months of age. They had actually been headbanging and caused 2 concussions by the time they were 10 months. So they came into our day treatment service. And then I've had individuals up to mid 60s, 66, 67 who had chronic self-injury. So full age range is what I do. And on an outpatient basis, we can see any age group, while our inpatient unit really sticks to under the age of 21. So my purpose today, I'm going to talk a little bit about talking about the common behavioral issues we see in SLO, talk about some potential environmental triggers of challenging behaviors, and talk about the various assessment and treatment options. So there are many behavioral issues that we have with our individuals with SLO. So some of the most common ones that you'll see in the literature when we talk about mental health concerns and perhaps dual diagnoses with SLO and a mental health condition, we see obsessions. I'm not going to go into any details on these. Elaine just covered most of these. Compulsions, anxiety, the selective mutism is one that we see more. And we have been very successful in using behavioral approaches to treating selective mutism, ADHD, and some mood disorders that Dr. Tierney reviewed. Some of the common behavioral phenotype characteristics that we see in SLO include the communication and language difficulties. In particular, what we see is the communication is one where we see the language impairment, where the expressive language is more delayed than the receptive language, meaning they're able to understand a lot more about what we're saying than they're able to express verbally. We also see the ADHD symptomatology and the irritability. In addition, the behavioral phenotype has identified aggressive behaviors in both children and adults, along with self-injurious behavior, in particular, the biting of the hands and the wrists. Headbanging has also been identified. And if my slides are going too fast, I know we're going to have them posted too. So the studies with Dr. Tierney had done with self-injury identified that about 89% of the subjects in this study that had 59 individuals had a history of repeated self-injury, meaning at some point in their life, they had displayed self-injury, whether it was younger or older, but at some point in their lifetime, they had that. 54% of that self-injury was the self-biting, mostly the forearms, and then the 48% had head-directed or head-banging. Dr. Tierney's also identified that autism is also highly correlated with the SLOS. Again, I'm not going to go into a lot of detail on those since she just covered it all, but we know that all of these behavioral symptoms and behavioral diagnoses occur, but we also know that for our kids, they're not always verbal or they're not able to express it to us. So how do we know about it? Well, we know based on their overt behavior that some of these diagnoses may be present. So now we're going to talk about, with those overt behaviors that we can see, what do we do about them? How do we address those interfering behaviors? Behaviors are interfering because the child is not able to access their community. They're not able to access their education. They're not able to access the social activities that we want to see them being able to do. So it's interfering with their ongoing development. Before I start a behavioral assessment, I'm going to do these things. First, I'm going to rule out that there's any medical or physiological problem, such as the ear infections, allergies, sinus infections. We want to get those treated first, and then we'll start addressing it from a behavioral perspective. If there's pain or discomfort, try to treat that. We're going to monitor for any tissue damage. That's really important because we don't want any infections to occur, which could exacerbate things. And then we're also, due to the risks that are associated with head-directed self-injury, I'm going to suggest that you get an ophthalmology exam. I'm going to want that retina evaluated to make sure there's no retinal detachment already. And also of examining the eardrums to make sure there's no damage there. So now that we've ruled out medical complications that we're going to address first, when it's a new or a mild problem behavior, I'm going to ask you to start looking at, is this something that's happening just out of boredom? I know I talked about it with some families already this weekend. You know, we're sitting here chit-chatting away and the child's like, I'm out of here. I'm done. I'm gone. Well, we're boring them to tears. So think about that and say, let's give them something else to do if we think boredom is a factor. How do we do that? Well, we start to look at this as a proactive treatment recommendation. It's something we're doing to actively put into place something instead of allowing them to get bored. So we're adding in some structured scheduled activities, teaching other leisure skills. Oftentimes I will hear families tell me they don't have any leisure skills or they just spend their time on the iPad. Well, that's where we're going to come into play with trying to teach new skills. These can be pre-academic skills or academic skills. It could be leisure skills. It can be play skills, activities of daily living, something that's going to help them occupy their time so they're not getting bored and tired of the same old thing, minute after minute, day after day, hour after hour, right? We need to have more in their environment that's stimulating for them. So those are some of the things that we're going to do is look at beefing up that schedule that of activities that they're engaged with. We also are going to look at coping skills. Now, our kids are all going to be different in terms of what type of coping skill is most appropriate for them. One of the things I see a lot in IEPs and in adult program in their individual plans is they just put a whole list of different things that somebody's told them are great coping mechanisms. Yeah, counting to 10, deep breathing. Well, I can tell you, there's nothing worse than having a child who's agitated and saying, okay, deep breathe now, come on. And they hyperventilate. Exact opposite of what we want, because no one ever taught them the coping skill. They just put it in a long list of things to try. I'm saying here is you need to overlearn that behavior with that child. They need to practice it. They need to learn it outside of the context of the situation that is going to produce that response. So if they're going to get anxious because they're in a new environment, don't try to use a breathing technique for the first time then. Teach them that breathing technique at home, at school, 2-3 times a day for 3 or 4 weeks, so they really know what it means to take a deep breath. Anybody trying to do belly breathing and try to learn how to breathe properly through yoga techniques or mindful meditation knows that it's not the way that most of us just normally breathe. It's a technique that you really have to learn. So these are strategies that I think are excellent. I think it's great if you can teach your child how to learn how to do behavior relaxation training or deep breathing. Wonderful ideas, but teach it outside of the anxiety producing context or disruptive behavior producing context first so that they know how to do it. So additionally, for a new or mild behavior problem, I'm going to ask you, think about how you're responding to that behavior. And I like to think about this, and all of us remember when your kids are learning how to walk and they're toddling around and they're going to fall. Well, depending on how people respond when they fall, they may have a really positive reaction and just bounce back up and walk. Or if you go, oh my God, are they okay? They may burst into tears. So think about how you reacted to that new behavior that you don't want to see again. And remember, don't give that big reaction. Try to just go about your business and say, okay, let's move on. For a new behavior, try not to provide any positive reinforcement. And positive reinforcement to you is different than positive reinforcement for somebody else. So the only thing about reinforcement is reinforcement always increases a behavior. So you might think that by reprimanding, you're punishing a behavior or you're going to have it decrease, but it may be a positive reinforcer. It may be exactly what the child's looking for, and they're going to keep doing that behavior over and over. I'm going to talk about that a little bit more. So now if it's not a new behavior problem, or you've tried all the things I just told you, and that's not working, we have a more chronic or ongoing behavior problem. I'm going to suggest that we need to start looking at why are they engaging in this behavior? And from my perspective, that's called finding out the function of behavior. Behavior psychologists, that's what I do. I look at function of behavior. Why do we need to know function? Well, because we could inadvertently be doing the exact opposite of what we want to do. So for example, reprimands may actually make the behavior worse because the child is looking for that reaction from you. So you may remember a kid, they'll do, one of your kids will do something and they look right at you like, okay, what are you going to do? They're looking to see, are they going to get attention for that? Example number 2, you provide a timeout. That might make it worse because they were trying to escape that activity. Cool. I just got sent to the principal's office. I missed physics class. Awesome. I don't have to do that today. Great. They got exactly what they wanted. So getting sent to the principal's office, going to timeout, they escaped that activity. It might be what they were looking for. So knowing the function of that behavior, we could have avoided those 2 problems. So we utilize function-based treatments, and function-based treatments have been evaluated since the early 1980s as a way to decrease problem behaviors in outpatient clinics, residential programs, inpatient units, short-term inpatient programs, at home, and through telehealth, and they've all been incredibly successful in reducing problem behavior while increasing appropriate skills. So that's why function-based treatments are so valuable. They really do work. Important points. It's really not as easy as it's going to sound. It's really a lot harder. It takes a lot of time to get your assessment right. And problem behavior is not like getting strep throat. There's not one thing. You don't have a problem behavior, take a pill, and it's gone in 5 days. It's something that we have to do the proper assessment, test out treatment strategies, and reassess to see if it really is reducing the problem behaviors. We have to really understand as much as we possibly can about the behavior so that we get the function right. Because if the function's right, your treatment will be right because you make it a function-based treatment intervention. However, if I get the wrong function, it's not going to reduce the behavior. Behavior is still going to exist. So how do we figure that out? And that's where somebody like me comes into play. We're going to use techniques of applied behavior analysis. So you're looking for a behavior psychologist. I'm a licensed psychologist or a board certified behavior analyst. They're certified by the BCBA. You can also talk to your insurance company about people who are in network. I can give you a lot of suggestions about people who do these types of things, but if they're not in your insurance network and it doesn't cover it, it's really expensive. So you can also reach out to your insurance company and ask them for recommendations on providers. You can also reach out to me. I'd be happy to help come up with some suggestions. And if they're not in your insurance network for any reason, they can help you find that within your states. I know I have a lot of colleagues around the country who have different outpatient and inpatient programs working with severe behaviors. So I can certainly come up with some recommendations. Or you can come to Maryland. I'm happy to see all of you, any one of you. First things we do when we're working on assessment and treatment of behaviors is we try to define those behaviors because I need to know what I'm looking at and I need to make sure that we're all talking about the same thing. So for me, aggression could be hitting and kicking, but for another child, it could also include biting. The other behavior that I often hear about is anxiety. I don't know what anxiety looks like for your child or for you or for me. For me, my anxiety is the fact that I'm up here pacing, I can't stand still. But it's me being anxious. But you wouldn't know that unless I told you what that definition of anxiety is for me. So I need to know exactly what we're talking about because it's a very data-based approach that we're taking, and we're going to have people collecting data on that behavior. So I want to make sure we're collecting data on the exact same thing. So Throughout this functional behavior assessment, we're developing hypotheses about why we think this behavior might be happening. And we're going to evaluate that over time, not just today, but we're going to look at it over the course of several days, over the course of different situations, over the course of different people that they're interacting with. There are indirect functional assessments, meaning it's just questionnaires. So there's interviews, there's questionnaires, but then there's the direct observation piece. And I'm going to talk a little bit about what ABC data is. But direct observation is really important so that the behavior psychologist or BCBA is actually observing what's happening in the environment, seeing why and when these behaviors occur. So somebody asked yesterday about, well, what are the questions you should ask? And I think there's like 3 slides, right? So we start off with some basic functional assessment questions. We call this a functional behavior assessment, or an FBA. You'll hear that in the schools, your school programs, when they have children who have behaviors, they need to determine that behavior is interfering with the child's progress in school, and they need to start by doing a functional behavior assessment. That is actually something that's mandated by law if the child's behaviors are interfering with their academics in the school setting. It's by IDEA. It's mandated by federal law, so it's not a choice that they really have, although schools are suggested it's a choice, but FBAs are not a choice. Behaviors interfering, they're required to do an FBA. FBA is then utilized to develop a behavior intervention plan, or a BIP. And again, if it's interfering, they need to have the FBA and the BIP. And if your school says they don't have to do that, get an educational advocate, which I can talk about more too. But it's required by federal guidelines. So these are some of the questions we're going to ask in a functional behavior assessment. When does the behavior happen? When does it never happen? I mentioned it yesterday. If it's never happening at a specific time, I want to know that, because that gives me ideas for treatment. It gives me suggestions about what I could do in those situations. We also look at what happens before the behavior occurs, what happens after the behavior occurs, thinking about if they're trying to communicate something. And I hear that a lot from families, like, I know he's trying to tell me X. I know he's trying to tell me something. I just can't figure it out. Does the child seem to be wanting a reaction from you? Is he trying to get out of doing things? Is it that they're having to wait for something? Is it that they're bored because somebody's been talking an awful long time? Do they engage in the behavior when no one else is around? That gives me another clue that there might be something more internally driven about the behavior. And does it seem to be in a very repetitive, ritualistic type of fashion? So we look at what we call a 3-term contingency. That's ABC. Antecedent, what happens before; behavior, exactly what that behavior is; consequences, how do we respond? So in this example, schoolwork was the antecedent. The behavior was he hit the teacher. And the third thing was that he got a reprimand. Don't do that. You're going to hurt me. Shouldn't hit the teacher. This is just another little example of how you might have data collected. You have a question? Yep. Okay. And I'm happy to share the slides with anybody. So you can email me. I'll share all my slides. Oh, easy. No, I put it on the website. I'll put it wherever you want. This is just another example. So if your behavior analyst would ask you to collect data, they may give you a data sheet that just says ABC, and this is the type of data they might be looking for. So antecedent told no to going outside, have an 8-minute temper tantrum, and then a reprimand, but they're still allowed to go outside. So that told me they got what they wanted. So the likelihood is the next time they're told no, they're going to have a bigger tantrum. It's going to be bigger and better because they got exactly what they wanted. In addition to ABCs, we also look at something we call setting events. And that's something that's a little bit further out in time, but it might be something that's setting the occasion for a behavior to occur. Child didn't get enough sleep. Child's sick, they have a fever. They're hungry or they're tired. There was the loss of a pet. That's why I suggest that when you send your child to school and you know your kid had a really rough day or something really significant had happened that morning or the night before, let the teacher know. That way they know that they're coming in already having, maybe a difficult time. And we all might want to know that so that maybe we don't present the hardest problems for them that morning. A functional analysis is a very specific version of a functional behavior assessment. So if the data from just the observations alone of the naturally occurring behaviors didn't give them enough information to identify function, we might do something more fine-tuned, such as a functional analysis. And that's what happens when a child comes to our clinic. The kids that come to me usually have had functional behavior assessments before. People have tried different things and they didn't work. So they come to our clinic and we do what we call an analog FA. And we actually set up the contingencies in the clinic to demonstrate the same types of possible functions of behaviors that might happen outside of there. In a functional analysis, which has been ongoing since 1982 and was developed on our inpatient unit that Dr. Tierney works at, different situations are set up and we evaluate whether the child might be engaged in problem behavior to gain access to attention, to escape work, to gain access to preferred items such as toys or tangibles. There's alone conditions to evaluate if they do this by themselves, and that might suggest a self-stimulatory or automatically maintained behavior. And the toy play condition is one that is actually just, it's the control condition. They get access to everything they like, they get access to attention, and no demands are placed. So it should be nirvana. So again, these are possible functions: gaining access to attention, gaining access to preferred things, escaping demands, self-stimulation. There may be others, or it may be a combination of multiple functions like this. So they might have the behavior to escape demand, but they're trying to get to a toy they want. And so it's a combined demand, escape, tangible type of situation. So we compare each of those conditions against the control, the toy play, to see that one function of behavior might be happening. So here's an example, and this actually is with an SLOS young adult in our clinic who we recently saw in the springtime. We conduct mostly parent-conducted functional analyses, meaning we actually teach the parents how to do each of these conditions. And where's the pointer? This one. Which one's the pointer?
The little green one on the bottom with the arrow. Yeah.
Okay, we'll just talk it through. Okay, along the bottom, the x-axis going this way. Sorry, I'm going to give you a little bit of a math lesson. X-axis sessions 1 through 21. These are 10. Each dot is 10 minutes. Okay. Across the Y, going up and down, is going to be responses per minute. So this is up to 5 responses per minute. Sure. Just as a laser. This is like, okay. Okay. All right. So responses per minute over here. Each of these dots I said is 10 minutes, and we have 2 different dots for every session. We have a dot down here at the bottom. That's going to be the condition. And then this top line, that is the percent correct implementation of the contingencies of the session for the parent. So that's parent behavior. And this parent did amazing, right? They did fantastic. Look, that's 100% right. That's awesome. We love that. So 10 minutes here, this is tangible. In that session, we evaluated whether the child engaged in the behavior to gain access to their preferred thing, which was an iPad. They did not have any behaviors to gain access to the iPad. 3 times, 30 minutes, no behaviors to get the iPad. That's good. This dot, that's toy play. That's our control. Again, no behaviors in toy play. So all of those things, no demands being placed, getting attention on a schedule, everything was great. What we do see is this child engaged in behaviors to get adult attention, meaning each time in that 10-minute social attention condition, each time they had a behavior, the parents said, oh, don't do that. You're going to hurt yourself. That's not, you don't want to hurt yourself. Child loved that. That was really nice. Twice a minute, that's pretty good, right? You're going to get, that's pretty much almost all attention all the time. So this tells me that we have a child who has behaviors to gain access to attention from the adults. So my treatment is going to focus on teaching them an alternative way to get attention from an adult. Okay, so I know the function. Now I'm going to go to the treatment. So our treatment options include a variety of things. We could do medication trials, we can do behavioral treatments, and we can incorporate protective equipment. Protective equipment is some of those strategies that Dr. Tierney reported about having Kevlar sleeves or a helmet. Those are all things that we might want to incorporate so that as we're going through the treatment evaluation, we're minimizing any potential for tissue damage at all. And then maybe over time, once the treatment is working, we can fade out that protective equipment. I say our gold standard is to try to combine all of these types of approaches so that we minimize any tissue damage, we minimize how much medication is needed, and focus on trying to get a behavioral treatment that's really effective. There's one slide on medication, which says there's not one medication for this, right? Just because your child has self-injury, it's head-directed, we don't know what medication to use. There's so many other variables to evaluate. So that's where you're going to talk to a psychiatrist or developmental pediatrician who has experience with SLO, or who is willing to talk to a physician who has experience with SLO. And that's really important. So we're going to take those results from our functional assessment, and we're going to evaluate one treatment component at a time to make sure that what we're suggesting is effective and reduces problem behavior. And if it's not working, we're going to drop that treatment and try something different. We want to establish and increase appropriate skills such as communication, leisure skills, or social skills. We want to change any antecedent situations that might be occurring that are leading to the problem behavior. And we also want to weaken consequences. If attention was the consequence that was keeping that behavior going, we want to eliminate that attention after the behavior to minimize that, okay? So we're going to increase appropriate, we're going to teach new behaviors, and we're going to increase those reinforcers in the environment. Reinforcement is really important. It increases our appropriate behavior. All reinforcement increases behaviors. If a behavior is increasing, they're getting some type of reinforcement, even if it's a negative behavior. Reinforcement, just the idea of reinforcement, it's increasing a behavior. So positive reinforcement might include getting an allowance, getting treats, or being allowed to stay up late. Negative reinforcement, that means we're taking something away and the behavior increases. You get a break at work, you turn off your alarm clock, you take medication, the headaches go away. These are all negative because something is removed and the behavior increases. What you think is reinforcing for one person may not be reinforcing for another. Oftentimes I'll see in a classroom environment, teacher gives out goldfish and thinks it's a reinforcer for everybody. Well, not every kid's behavior improves. Well, they don't all like goldfish. I use myself as an example there. If you were to give out Reese's peanut butter cups to everybody in here, and all of you, sat nicely and got your Reese's peanut butter cups, I would be standing because I'm allergic to Reese's peanut butter cups and I'd be at the ER. So I wouldn't want that Reese's peanut butter cup. It would not help me in any way, shape, or form. So you wouldn't see my appropriate behaviors increase in any way. You want to make sure that what you're using is actually a reinforcer for that child. How to do that is through doing preference assessments. I'm not going to go into detail on that, but basically there are strategies to use to demonstrate that something can be a potential reinforcer. And again, we did this with same child with or a young adult with SLOS. And we evaluated using a STEM choice preference assessment. Basically, we paired two items against each other that we had done a parent interview with and identified their most preferred things in the world. We paired them up and the drum won out. They selected at 86% of the time, followed by a camera, a ball, SpongeBob, our outpatient iPad, and on down. So the iPad didn't come out one. We were very excited about that. We now have this lovely drum. Imagine using that as your reinforcer all the time. Wouldn't that be fun at home? That'd be great. Yes. So we also have a little camera that doesn't make nearly as much noise, but it had some flashing lights or something. So we do a preference assessment to identify items that we can use as reinforcement. And that gives us a variety of things we can choose from. Basically, in a typical preference assessment, anything above 70% will function as a reinforcer. Anything under that is not as likely to function as a reinforcer. There's a lot of research on that. You don't want to know about that. So some common treatment approaches. These are some of the most common ones, and I'm going to go into a little detail on each one and try not to keep you here all night long. The one in yellow at the bottom, oops, that was my fault. The one in yellow at the bottom is in yellow because it's technically considered It's technically considered a punishment because it's actually trying to decrease a behavior. And by definition, punishment decreases behavior. So the other ones are white. They're all proactive and reinforcement-based strategies. The yellow is a little bit different, and we'll talk about why that is. So some proactive procedures include redirection, which is simply means you're not going to say anything about that behavior, and you're just going to redirect to the activity that they should be doing or something else that's in the environment that they can engage with, or whatever else is on their actual schedule. And then as soon as they're engaged in some other activity other than that behavior you want to decrease, a lot of praise. Lots of praise, lots of positive reinforcement. We're going to also teach appropriate replacement behaviors. And this is one where you have to know the functional reinforcer so you know what replacement behavior to use. So if their behavior was access to attention, we want to teach them a way to communicate that they want attention. So that could be handing over a picture card, it could be touching a picture card, it could be using a voice output device, but functional communication allows your child or your individual to request the things they want using a functional means of communication as opposed to their behaviors. So what we would do is we would reinforce the communication that's asking for attention and not provide the attention contingent on their challenging behavior. We'll utilize functional communication along with putting it on schedules and in pictures so that the child has a means of knowing when that communication is available to be used. I call it signaled availability, not just me, but the field calls it signaled availability, putting it out there that the attention or access to a tangible item is available on either a set schedule or available at times and not available at other times. If you use a red-green board where red means it's not available and green means it's available, things on the green side right now, they're available. Things on the red side, it's not an option right now. So they wouldn't get access to the things on the red side, but they can have access to all the ones on the green side. Really helpful because it allows your child to know what they can get at that time. While I think we all assume that they know what things are available and when they are, it's always the case that as soon as I get on the telephone, my kid wants me, right? Well, that's when things become available. That might be when the iPad is now available. It becomes green because I have to take a phone call. And when I get off the phone, it's back on red. And now it's time for us to do something more socially engaged or do some other activity. Behaviors maintained by access to items. Again, you're teaching functional communication to gain access to that item, teaching them a way to communicate to get that, whether it's a voice output device or a card. And then escape maintained behavior, meaning they're trying to get out of doing their work. So here you're going to teach them a way to ask for a break. And that would be, break please. They can get a short break after doing a certain amount of their work. Over time, you can gradually increase how much work is required before that break is available. We're also going to utilize strategies, prompting strategies to teach them that when you ask and utilize or you ask for a demand to be completed, that you always follow through. If you don't follow through on a demand, what they learn is that your demands are not going to be followed through on, and it doesn't mean anything. So I tell most of my families, I would rather that you every day place one demand and follow through on that demand so that they know when you ask them to do something, you mean it, than ask them to do 10 different things and follow through on none. Because then they've learned 10 times in that day that you don't follow through on what you say. So it's really important for the follow through so that they know you're going to follow through and you're going to make them continue to do that activity. You can also add in more breaks, and you can also have rewards for compliance. So the more compliant they are, the more access they get to their most preferred things that might be from your preference assessment that you had done. Differential reinforcement strategies are just different ways of looking at providing reinforcement. A DRA means you're reinforcing alternative behaviors. You're not going to say anything or do anything about the inappropriate behavior, but you are going to reinforce compliance. You are going to reinforce appropriate communication. You are going to reinforce an alternative positive behavior of theirs. So it teaches them that there's a way to get the reinforcer they want, but it's with appropriate behaviors. So for example, a child gets attention for sitting in the chair quietly or for completing academic tasks. So they might have been looking for attention. They got it for the appropriate behavior of sitting nicely. Differential reinforcement of other behavior means you literally reinforce every other behavior other than the problem behavior at hand. So as long as they are not engaged in that self-injury, you can say, wow, I like the way you're standing. Wow, I like the way you're wearing your blue t-shirt today. Sometimes we run out of things to praise. And so you might just, I like the way you're wearing your hat today. That's fine. But they're getting your attention. So if an example of a DRO schedule might be if Charlie doesn't bite his hands for 10 minutes, he receives game time at the end of the 10-minute interval. And then there's non-contingent reinforcement, meaning that we just put that, you just set a schedule, a timer, that every 5 minutes you provide the reinforcer. Every 5 minutes they get a break, every 5 minutes maybe they get attention, but you just have a set schedule. That means that you don't have to necessarily witness that they didn't have a behavior to gain access to the reinforcer, just you set a schedule that they're getting high enough levels of reinforcement. So for attention maintained behaviors, the functional communication, perhaps picture communication systems, or the differential reinforcement of alternative behaviors or other behaviors. Ignoring, I'm going to talk about that a little bit. I'll skip that one right now. Blocking behaviors. If you have self-injury, you may want to block that behavior. Sometimes blocking could be a form of attention. It could increase a behavior. So we test that out very carefully in our clinic to make sure it's not increasing the behavior. One of the things, our clinic is very different than others. I don't ever send you home with a treatment component until we tested it out in our setting to show that it works. So I won't send you home and say, go give it a try. I'm going to make sure it works before I tell you to do it. Sometimes blocking will increase behavior because the kid might be trying to get that attention. For access to attention, or child engages in the behavior to get access to an item, a tangible item, not commenting on that behavior, not providing them access to that iPad. So they're having a tantrum, they want the iPad, they want to go to the pool. We're not giving them the pool right now. They have to be calm or quiet. And then later on, when they've had good behaviors, that's when they're going to get access to that preferred item. Escape maintain behaviors. Again, this is a time when you could teach them how to ask for a break, but you're also going to use a prompting strategy where you're sequentially providing a higher level of prompting to have them comply with the demand. So that's this least to most prompting strategy, where you give a verbal prompt, then a modeling prompt or a gesture prompt, followed by guiding them through the task, so that they learn that even though they didn't do the task independently, you're going to make sure they follow through and do it. Last one is behaviors maintained by physiological consequences, meaning more internally driven. Those are what we also term automatically maintained behaviors. So those are going to be the ones that are the most challenging. We try to increase the overall level of stimulation. We try to increase the overall level of sensory input, looking for things that might provide them with similar sensory input to replace the inappropriate behavior. We're going to block and ignore most likely because we don't want to cause any tissue damage. We also try to teach additional leisure skills or toy play skills so that they have something else to do instead of engaging in automatically maintained behavior. So it could be any kind of self-injury that's automatically maintained. We also may try protective equipment. That helps us block the sensory input that they might be getting. So that might be the helmet, it might be arm restraints or Kevlar sleeves, something to block that input that they're getting from engaging in that self-injurious behavior. If the behavior continues to persist with the behavior treatment, so we go to adding in some protective equipment, we do try to make it as short-term as possible so that we minimize the damage that they might be causing. But then while they're in the protective equipment, trying to, again, teach new skills and add in other components. It may be also a time when they're doing other medication trials so that we may have to have the protective equipment in place for a while we are evaluating to see if there's an effect. We always try to be the least intrusive as possible and try to fade out the protective equipment as early on. If your child is wearing any, if a child is wearing any type of device that is limiting their range of motion, So that would be if the child is having head-directed self-injury and they put them in arm splints that are actually rigid. There are requirements to remove those and allow for range of motion so that you don't have any damage to the muscles. You don't want to have any weakness of the muscles. The other goal is to decrease the problem behaviors. And this is where I said that other thing that extinction and ignoring behaviors comes into place. Decreasing a behavior could include something that's called a punisher. Punishers, by definition, in our little behavioral world means you're trying to decrease a behavior. So extinction or planned ignoring for attention maintained behaviors means you're not going to provide that attention. We want to make sure that when we put this into place, we've actually already increased attention for other things. We've increased the reinforcement for many other behaviors. So they're getting the same level of reinforcement, but we're going to take away the reinforcer of attention for the problem behavior. When I start a behavioral intervention, I always start by having people increase the reinforcement in general in the environment before ever adding in a extinction component where you're withdrawing reinforcers. When you're teaching a behavior or you're using extinction for a escape maintained behavior, you're making sure you don't allow escape. So you have to follow through on the demand so that escape is not an option. Oftentimes when we use an extinction type of approach, you will see increases in behaviors before you see decreases, which is why it's so important to make sure we've added in that other attention and other reinforcement early on so that we can actually remove the attention or any other reinforcer for the problem behavior. With this idea, it's kind of doing the opposite of what the child's expecting. So child wants to get a reaction from you. You're going to ignore, block and ignore that behavior. You're not ignoring the child, you're ignoring the behavior. Child wants to get out of doing something. Again, ignoring the behavior, following through on the demand. Keep going with what's on their schedule. Child wants something they can't have. You can tell them no, and then you ignore the behavior and get them busy on something else, redirection. And last one, child seems to be doing it to get some kind of self-stimulation, and we're going to try to block and make sure they're not getting that stimulation, but getting some type of stimulation another way. Best outcome is that we have a combination of the behavioral medication and proactive strategies with the protective equipment. This is just, this is my last one, I promise. This is actually a treatment evaluation, again, with my young adult with SLO. And this data demonstrates the baseline where we had these rates of behaviors to gain access to attention. Treatment, they all go all the way down to almost zero. The red dots are them using their functional communication response. We do a reversal to show that it really was the treatment. So we go back to baseline here. And then we gradually fade how often the FCR, or the functional communication response, is available. So first there was 1 minute where there was no access, then there's 5 minutes of no access, then there was 8 minutes of no access. So they couldn't ask for attention for 8 minutes, and the behaviors remained at that zero level. So this graph demonstrates that it was very effective, and it was the treatment and not some extraneous variable. So you're going to get a behavior plan. Important to be trained in your behavior plan. I'm going to go through the last slides really fast. You want to make sure it's working. You want to make sure you as a caregiver, you're the parent, you need to know how to do this plan, not just whoever developed it, but you have to know how to do it, because that's what's going to be the most effective part. Then you're able to continue to do it. With school, make sure they conduct an FBA and implement a BIP. I suggest that you guys work collaboratively, because strategies that are working there may work for you at home as well. That's what that says. So we can decrease problem behaviors. We just need to monitor the behavior and conduct the functional behavior assessment, evaluate the strategies that are working, and then implement it in the natural environment. And really, it is possible to change these behaviors. We just need to keep at it and be really persistent.
Those were two encouraging talks. A lot of information there, and so I bet there are questions either here in the room or online. Who has a hand up that they'd like to be handed a microphone? One right up here, Marty.
Have you ever been unsuccessful with treating some people? I'm sure you have
Yes.
all kinds of behaviors.
Yeah. So.
I mean-
Our overall data from our clinic, and it includes all of our population in our outpatient program. So for the 5 years prior to the pandemic, because I have not evaluated data since the pandemic, just been a little busy with the pandemic, I guess. But the 5 years prior, 86% of our population has an 80% or greater reduction in problem behaviors. And then another 11% have a 70 to 80% reduction. So it's just that smaller, and whatever that number is after I took 86, 96, 98%. So about 2% that don't achieve a 70% reduction. So what I can tell you about that is that those clients that didn't achieve that reduction in behavior, one was that they were older. They came to us after the age of 15, I believe it was. That they had behaviors that were multiply maintained, meaning there were more than one function. So it wasn't just attention, but maybe attention and escape from demands. And the third was that they had a genetic disorder. So the clients that didn't achieve that had all those three things. They were older, had a genetic disorder, and multiply maintained behavior.
So you want to catch them early on and
You
train
want to
them.
catch them as early as possible.
Training is the right word.
Yeah.
And then later when they're older, it's just,
Well, it's
they
hard.
know all the tricks, so
Eh.
they just won't.
Yeah, so it takes,
comply with your
it'll take
demands?
longer is what we basically found too. I didn't include that part. In our intensive outpatient program, we see them for an average of 15 days of 5 hours per day. And for the kids that didn't achieve that 70 or greater % reduction, they also had been seen for less than the 15 days. It actually had been 10 days or less. So I'm encouraged that maybe if we had them longer in the service, that we would have done better. And so when I get a client that meets the profile that I just described, I always tell the families, I'm not putting you in for a 15-day admission, I'm putting you in for a 20 to 25-day admission instead, because I think I just need longer time.
Good, thank you very much. Other questions?
If not,
There's one over here.
I have one because I've asked you like 2 days ago about that weird thing, that behavior with the head. Like I saw it, that kid can do this, from the back to the front with a lot of strength, which is not safe way to self-stimulation. And I know that my patient will go to the preschool next year, and there will be a lot of emotions, and it can, be worse and worse. So how prepared the teacher?
Yes.
Because I'm not gonna be there,
You're
at
not gonna
home.
be
I
there.
know what to do at home
Right,
now,
right.
especially, but what to do, in preschool, in school.
So talking to the teachers ahead of time is one of the strategies I try to take, getting them prepared to understand that these are the types of behaviors they may see and what they should and shouldn't do. Most teachers aren't going to know a thing about SLO. I mean, the majority of them are not going to know anything. So providing them with some input, there's certainly articles about SLO that we could give that would be very nice that they could review and evaluate. I'd be happy to talk to people, but telling them up front what the behaviors are that your child might be exhibiting and letting them know strategies you're using at home that have been effective. I think that's going to be your most valuable resource because they're not going to know enough.
and it truly helps to have a teacher that's cooperative and willing to learn. We had some situations with Ashton a few months ago, and eventually his teacher is actually asking how to watch his conference. So it was really neat. So I haven't seen her yet, but she has the link and stuff like
Yeah.
that for the videos. So.
Yeah. And I think that goes not only teachers, but your professionals, your pediatricians who are willing to talk to professionals who know about the disorder, your, psychiatrists who are willing to consult with other psychiatrists who know more about it. Yeah.
And I don't know if this helps, but I sent a helmet to the school.
Yeah.
And I said, if he tries to do that, just put on his helmet. And he stopped the headbanging because it really embarrassed him to wear the helmet.
Yeah,
So
yeah.
you find out the things that work for your kid.
Yeah. And that's really important because you are the best expert on your kid. And so you telling the teachers what to do is really helpful.
So there are a few online questions too. It's a combination of both Dr. Tierney and Dr. O'Connor's presentations. The first question is there any scientific research on cannabis to treat behavior problems and with kids with SLO?
I don't have any data on that. And Dr. Turner, you don't have any data on that. No.
That's something we ought to do. And anybody who wants to participate in our studies, I guess we could probably have a link put on the foundation or our email addresses. I have consent forms too that if you sign it allows me to keep your contact information, but I think I can put that on the foundation website as well.
But I don't know anybody who's actually studying cannabis.
Oh, cannabis. I'm sorry. Sorry. I missed the cannabis part. Oh, I'm sorry. I missed that word. Sorry. No, no, I don't know of anybody studying cannabis use. I do have to say we have to be careful with cannabis use. There's very clear data in the typically developing population and children and adolescents that the more cannabis used, the higher the rate of schizophrenia and psychosis, which are lifelong disorders. So it's unfortunately there's going to be an explosion of these disorders now that cannabis is legalized in a lot of states.
Interesting. Another question for Dr. Tierney, during your presentation. What is the prevalence of bipolar disorder amongst SLO population? You have spoken about children presenting with mood fluctuations. At what age are SLO children typically diagnosed as bipolar?
Gosh, I don't know don't know how much bipolar in the general population. It's 1 to 4%. I suspect in SLO it might be the same. I do know one little child at the age of 4. When I saw her at NIH, and I'm like, I think this is bipolar, and she was diagnosed with that later. But yeah, I need to do a better job of tracking all of this, like keeping track of people and what diagnoses they come and what meds they're on.
The next question is, for the packets that you've been passing out, how do the virtual users receive that information?
Yes, I apologize. I think those have been emailed out. Kelly, Noah? She said.
What's that?
Yeah, they're
Yeah.
PDFs.
Okay, that'll work.
Yes. One thing, Kelly, I don't know if I gave you the PDF of the lecture slides. Yeah, I can fix my typos. No, just go ahead and send them. I'll fix them before the next conference. But all the others are there. And they're also on the, all of the handouts I gave, other than my lecture slides, are if you Google Autism Speaks toolkits, they're there. And something I didn't mention reminds me, that is also a resource finder. I know I mentioned the other day, you can state where you are and it can tell you what autism clinics are in your area, or at least in the US.
What should they Google?
Autism Speaks and then toolkits, or just Autism Speaks, and you'll see there's a resource section. You can click off like, are your family member, they have the toolkits, which are these handouts and PDFs. They also have all kinds of other articles and resources.
And last online question is, how do you work with the SLO individuals to help them be truthful and respond to others with what they actually think, and not respond with what they think the other person wants them to say?
I don't have an answer for that.
It's pretty tough.
Yeah, I'd say maybe work with a therapist to try to work with that person to help them communicate. And I don't know, it's a little more complicated.
Yeah, I have to know more about why they're. I don't know if just my, oh, you turned it off. I have to do that. Okay. All right. I'd have to try and figure out more about why the child might be trying to tell you what they think you want to hear. I'd have to evaluate that a little bit more clearly.
It's an interestingly complex question.
It is.
You have an opportunity this afternoon between 5 and 7 to bring your complex questions to Dr. Tierney, for she is still taking appointments either through Kelly. Does she do that through you?
Oh,
Also, there's a link that has been sent to all of us, and so you can also get that link from Kelly or from someone else in the board, so that excellent. And then that information can be shared. And I can tell you that those sort of in-person consultations have been so helpful to us and have been encouraging, at least to us, to ask our doctors and our kids psychiatrists to consult with Dr. Tierney. And that's been a way that they can benefit from her expertise. Dr. Tierney, Dr. O'Connor, thank you so much for those excellent presentations this afternoon.